Hello, everyone. Good morning, good afternoon, good evening. We're just about to get started. I'm going to give us a moment for people to arrive into the call before I kick this off or before I hand this on to our presenters to kick off. You can see quite a number of people joining. And I think I'll go ahead and get us started. So welcome everyone, good morning, good afternoon, good evening. Thank you for joining us for this webinar, Principles to Practice, How Momentum Private Healthcare Delivery is Operationalizing Meaningful Adolescent and Youth Engagement. And I will be just doing a quick welcome and a couple of housekeeping items before passing it on to our presenters. So welcome everyone. Please do introduce yourself in the chat. There are a number of us here today and we would love to see who you are and where you're joining us from. So please do introduce yourself in the chat. We have a number of presenters joining us today. And we're going to start with some words and some presentation from them, followed by Q&A, questions and answers towards the end. So please do be writing in your questions. Go ahead and put them into the chat box as we go through the presentation. And know that we're collecting the questions to spark discussion at the end of the webinar. This presentation will take place in English and in French. We have presenters presenting in both languages. So please be sure to select your interpretation line now. You can find that button at the bottom of the Zoom panel. And you can go there to select to hear in English or in French, or if you are bilingual in both languages, go ahead and stay as is. And then just a quick note that this meeting will be recorded so that we can share it again later. And with that, I will go ahead and kick it over to Amy Ocello, the Senior Youth and Reproductive Health Technical Advisor for USAID, to really get us started. So Amy, over to you.
Thanks so much, Alexandra, and welcome everyone. Great to have you in this conversation. The presenters are going to share a few reasons why MAYE, that's Meaningful Adolescent and Youth Engagement, is an important intervention for the private sector. They're going to share with you 3 stellar examples of how they've incorporated MAYE and some key resources. What I'd like to highlight are a few points about MAYE accountability in the global health space and a few MAYE opportunities that can be used in the private sector, as well as a couple of considerations when applying MAYE. So next. So to start, let's consider, is MAYE nice to have or a priority? Where does it fall in the family planning and reproductive health space? Are there expectations and accountability requirements? Next. On the global stage, there are greater calls for MAYE accountability and FPRH interventions that try to move us from the rhetoric towards greater action. There's the Global Consensus Statement on Meaningful Adolescent and Youth Engagement. And since its signature by 250 different organizations, the implementers have been looking towards increasing the accountability measures. In 2021, a survey tried to inquire what progress had been made on MAYE by all of these organizations. And there were some notable successes, but they were more particular with the youth-led organizations than with all the other INGOs. And there were still persistent barriers like racism, misogyny, and ageism that keep MAYE from moving forward. So they hope to continue to track this progress. And I hope that you take a look at the linked report to see where you can possibly pay attention to some of these challenges and barriers in advance. Next. USAID has also doubled down on youth engagement in the recently updated Youth in Development Policy released this year. Next. The policy prioritizes positive youth development as a key agency principle and lays out greater expectation for implementers to support youth as emerging leaders and vital partners in development efforts. It recognizes MAYE as essential to our inclusive development goals and a matter of social justice. The Office of Population and Reproductive Health will continue to track PYD efforts, including contribution. And there are a few of us advocating for more youth involvement to go into our solicitation language so that it will be from the outset of the procurement. So stay tuned for that. Next. I'd also like to note that there are plentiful opportunities for MAYE in the private sector. There are multiple options, but as the space evolves, it's also clear that not all MAYE is created equal. There are lots of folks who are digging in deep, supporting youth leadership at the national level, or youth-led social accountability to drive service delivery adaptations and improve quality of care. However, most really, are still just scratching the surface. MAYE has been found in familiar places, such as human-centered design or demand generation and mobilization efforts. Although incredibly useful, these efforts do not necessarily represent the deep and sustained involvement we hope for in MAYE. They tend to keep youth as participants rather than as partners. It's great to see this work, but there's always room for improvement. Next. I'd like to take a moment before I show you some options to remember that not all private sector actors are the same. There are private civil society organizations with mandates and activities that can be very wide-reaching in FPRH. There are public-private associations that sometimes act as an extension of the public sector. They have great relationships with the government and may be more aligned to those priorities. There are also traditional for-profit clinics and drug shops, and a multitude of others. Each may have their own motivation or resistance to MAYE, be it a commitment to respond to the needs of their community, or being fearful to stray too far from the requirements of their funders or the government oversight, or the profit margin that they try to keep. It's a reality of our private sector actors. As you partner with these groups, it's important to assess and identify their motivations and match the opportunities I'll share with you on the next slide to best meet those needs. Next. So here are just a few examples of ways that you can apply MAYE to the private sector. And although there's no predetermined perfect amount of MAYE required, generally more than one effort will show how MAYE can be mainstreamed into the work, and as a result, the health outcomes will be improved. I've highlighted these examples into 3 categories: in informing our direction or design, in delivering our programs, and evaluating for success. I won't read all of them, but I'll highlight a couple. For example, as we think about informing direction for FPRH, we have the opportunity to form or tap into, if they already exist, youth advisory councils. And they can speak to groups such as pharmacy boards. They can inform government decision makers about universal health coverage decisions. And they can work alongside the Ministry of Health at national or district levels to ensure that there's sufficient budget allocated for youth initiatives. We can also build the capacity of youth-led organizations, funding their work so that they can be key partners in service delivery. We have to remember that these partnerships need to be formalized, not informal. So they require memoranda of understanding, contracts, terms of reference, etc. When we think about delivering programs and services, youth can be incredible staff members and need to be properly recognized and compensated for their work. They should have a say in mission statements of the organization, strategic plans, internal policies, and decision-making at all levels of the organization. I'd also like to remind us that USAID's age range of youth is up to age 29. That means many youth are also providers of reproductive health services. They're drug shop owners, some are pharmacists. How can we engage with them different than adult providers in order to improve youth access to contraception? Finally, in evaluation, it's just as important for youth to evaluate the success of our programs as to design it. MAYE assessments help organizations create action plans with short and long-term goals, and training youth as researchers, data collectors, and analysts, and bringing them into social accountability allows them to hold decision makers accountable for their SRH needs. Next. Finally, I'd like to end with a couple of considerations. Next. So we recognize that in order for the inherent objectives of MIYE to achieve equity, to dismantle power dynamics, to address inequitable access to financial resources, and build trust and inclusion of youth perspectives, there are barriers that are rooted in privilege and hierarchy, which prevent adolescents and youth from real meaningful engagement in decision making. It'll take a shift in power. Institutions should ask whether youth involvement that they do support remains a series of one-off assignments, or if their participation is systematically woven into the decision-making and plans for success. And real commitment by the private sector might mean changes to the organizational charter, structure, or culture, maybe removing unrealistic expectations or qualifications. Resources to fund youth capacity building so that they have the skills to equally contribute. And I'd add patience for stepping into a new space while there's still plenty to be learned. Next. Finally, we can't know how well we're doing if we don't measure progress. And although it might not be required yet, MAYE indicators do exist. Here you'll find the Positive Youth Development Measurement Toolkit, which has indicators, illustrative indicators that can measure contribution. We hope to see the linkages between MAYE investments and health outcomes, such as increased access to contraception, and tracking closed referral loops would be a good example of this. But I encourage you to, at any point possible, try to bring in some measurement of MAYE so we can track that progress. I want to thank you for your time and am now delighted to introduce the speakers for today's session. So we have as our moderator, Nina Shalita. Ms. Nina Shalita is an experienced development professional with nearly 20 years of experience in leadership roles, working in maternal child health, sexual and reproductive health and rights programs. She's worked in numerous countries in Africa, such as Uganda, Rwanda, Burundi, DRC, and now Mali. She's currently the chief of party for MPHD at PSI Mali. And during her free time, Nina enjoys listening to music and she loves dancing. Ibrahim Traore is the youth program coordinator for MPHD Mali. Ibrahim is the youth program coordinator, and he's a committed young man with more than 8 years of experience in the field of reproductive health and sexual rights of adolescents and youth. A specialist in communication and marketing, he's a dynamic, committed, and proactive in all that he does. The tenet he keeps at heart to always see the side of young people. Louisa Pulani is Deputy Head of Reproductive Health, PSI Malawi. Louisa is a public health leader with more than 20 years of NCH FPRH clinical, instructional, and program implementation experience in Malawi. In addition to technical expertise, she also possesses expertise in health system strengthening, Sbcc, adolescent reproductive health services, and quality improvement. Currently, Louisa serves as the Deputy Head of Reproductive Health for PSI Malawi, which includes acting as program lead for the MPHD activities in Malawi. and Noel Adalu, a social media manager for youth health programs in MPHD Benin. Noel holds a master's degree in socioanthropology of health and is a social media manager with 6 years of professional experience in the field of sexual reproductive health and rights. His main area of focus is on the promotion of digital health interventions, particularly on the use of social networks and social media networks for social behavior change. I'm delighted to invite these presenters to share with you their great work, and I will pass this on to Nina, our moderator. Thank you.
Hello, and thank you, Amy, for the introduction. As Amy mentioned, my name is Nina Shalita, and I work with Momentum Private Healthcare Delivery as the Chief of Party in Mali. For this webinar, I'll be acting as your moderator. Before I get started with slides, I'll actually start with a question for you, the participants. In just a moment, you should be seeing a poll question appear on your screen, reading, how would you rate your own expertise in meaningful adolescent and youth engagement? I'm an expert in all things MAYE. I've been exposed to MAYE, but it's still a bit unfamiliar to me. What is my I'm here to learn? Please take a minute to respond. Okay, wonderful. It looks like we have some answers. And it does look like we have a variety of levels of experience with meaningful adolescent and youth engagement, or MAYE. Some of you are experts, and today, hopefully, you'll learn something new from the concrete examples of operationalizing MAYE, and that we'll share over the course of this webinar. Others responded that you're newer to the ideas of MAYE, which is great. This webinar will hopefully provide a wonderful introduction for you. And with that, let's move into the content of the webinar. Many of you have seen this description of meaningful adolescent and youth engagement before, but of those who may be seeing it for the first time, I want to walk you through it. Throughout the presentation, I will refer to the meaningful adolescent and youth engagement by its acronym, MAYE. Meaningful adolescent and youth engagement, MAYE, is an inclusive, intentional, mutually respectful partnership between youth and adults. Through a MAYE approach, power is shared, respective contributions are valued, and young people's ideas, perspectives, skills, and strengths are integrated into program planning, design, and implementation. MAYE recognizes young people as experts regarding their own needs and priorities, while also building their leadership and workforce capacities. I know that this is a detailed description. Today's webinar will help operationalize some of these MAYE concepts, such as intentionality and building young people's leadership workforce capacities based on MPHD activities. Next. Now that you know that meaningful adolescent and youth engagement is, I want to talk about why it matters. Many organizations have been thinking about youth engagement for a long time, while for others, it is a relatively new technical approach. As we just heard from Amy a few minutes ago, MAYE is no longer a nice to have. Instead, MAYE is a right for adolescents and youth because it has demonstrated effectiveness in improving quality and responsiveness of SRH programs and policies and can lead to improved development outcomes. Numerous donors, implementers, and providers have recently recognized the need to involve young people in programs and services for them. While engagement of youth is necessary, it is not sufficient to engage a group of young people in designing a new program or service and consider it done. It is also highly insufficient to engage young people poorly or without careful thought and intention. Doing so risks losing trust and connection with the very population you mean to serve. Instead, meaningfully engaging adolescents and youth ensures that it is done in a thoughtful way, following the specific principles you saw on the last slide, such as viewing young people as experts or integrating their ideas into program planning, design, and implementation. MAYE also needs to be sustained via long-term engagements where youth are seen as partners with decision-making power rather than as mere participants in one-off engagements. Engaging youth in this way can help shift gender and social norms and can support sustained community outcomes and long-term contribution. Next, please. Now, some of you may have tuned into a webinar 2 weeks ago organized by the IBP network on the HIP Family Planning Strategic Planning Guide on May engagement in adolescent sexual and reproductive health programming. That webinar, which was recorded and can be accessed via a link on this slide, provided a deep dive into the publication shown here, which addresses 5 steps in the process of meaningfully engaging adolescents and youth. The first step is to prepare your institution, project, or initiative to meaningfully engage and partner with youth. This may be done through conducting an internal assessment or creating an action plan and changing policies, systems, and processes. The second step is to determine which youth to engage and the mechanisms of engagement and partnership. After deciding which youth to engage, this step consists of co-creating the scope, purpose, and mechanisms of the engagement and partnership with youth. The third step is implementing the engagement and partnership with youth. This step is comprised of developing written agreements to formalize partnerships, establishing fair compensation, providing ongoing capacity development, and ensuring continuous trust and learning. The fourth step is monitoring, measuring, and being accountable. This step is realized by monitoring and evaluating MAYE and partnership, and by establishing accountability mechanisms. The fifth and final step is sustaining youth engagement and partnership by planning for long-term relationships with youth instead of one-off engagements. The presentations you will hear today focus most closely on the second and third steps, but MPHD is working on how to incorporate the other steps into its activities. At this point, we have a next opportunity to engage you all with another quick poll question. The question should be appearing on your screen reading. In addition to engaging with young people, MPHD engages with private sector actors. Which of the following are examples of private sector actors? Select all that apply. 1, drug shop owners. 2, public hospital staff. 3, providers at private clinics. 4, social media influencers. Please cast your votes now. Okay, the votes are in, and I see many answered correctly. 3 of the 4 answer categories, 1, 3, and 4, are correct, as they are private sector actors, and only number 2 is incorrect. The private sector can encompass a variety of actors and partners, as well, look at a bit more closely in the next slide. Next, please. MAYE is a technical approach that is gaining momentum across a variety of programs and initiatives. It can be integrated into activities that are youth-focused, where youth are primary program participants, youth-led, where the youth are the primary implementers, or youth-relevant, where there is a youth-specific component or youth are within the target beneficiaries. The Momentum suite of awards is working across a number of health areas and sectors, all keeping MAYE as part of their broader goal. In particular, Momentum Private Healthcare Delivery, MPHD, is keeping MAYE front and center across our work on the intersection of the private sector and FPRH MNCH. MPHD is currently engaging in an interactive process of putting MAYE into practice. For example, we're moving beyond leading youth-friendly health services trainings for providers, which addresses only the supply side and whose benefits are difficult to sustain. We MPHD are learning and adapting from lessons like that and considering how instead youth responsive approaches like adolescent responsive contraceptive services, including MAYE as an essential element. Approaches like this seek to address gaps at the health system level. So these interventions may prove more sustainable and have longer term impact. We are striving to find new, more sustainable ways to meaningfully engage adolescents and youth across a variety of activities. And today you will hear case studies from 3 of MPHD countries, Mali, Malawi, and Benin, on operationalizing different aspects of MAYE. Next, thank you. As I mentioned on the previous slide, MPHD is implementing MAYE in its work with the private sector. MAYE isn't a public or private approach, but there are a few differences then thinking about how MAYE may be applied in the private sector. Evidence shows that the private sector is an important source of family planning for different segments of young people. Young people may believe that the private sector offers more anonymity and less judgment. Young people may also think that the private sector offers more convenient hours and a decreased chance of being gossiped about. Offering family planning through different channels, including the private sector, can reach specific segments. For example, in Nepal, PSI found that pharmacies outside of town limits were the primary source of condoms and emergency contraceptive pills for boys procuring on behalf of themselves and their girlfriends. Since young people encompass ages 10 to 29, this means many private health workers like drug shop vendors or IPC agents may be young themselves. While the private sector may be primed to engage with youth, it's often left out of public sector priorities and initiatives because providers are not systematically engaged. If providers are members of a private association or other network, they may have more opportunity to learn about national goals and access new training, but this is often not the case in many countries. Next. Building on the steps in the strategic planning guide on MAYE, we would like to discuss what it takes to operationalize it in practice. The list is illustrative, though not exhaustive, of what it takes to operationalize MAYE. First and foremost, You need staff willing to integrate aspects of MAYE into existing programs and practices, and an institutional readiness and commitment to MAYE. Second, creating budget lines for MAYE means it will not be an afterthought. Instead, there will be dedicated funds earmarked for meaningfully engaging adolescents and youth. Third, because measurement is one way to hold ourselves accountable as practitioners, we need indicators specific to MAYE. The strategic planning guide on MAYE had some example indicators, but we also encourage organizations to be thoughtful and add contextually relevant indicators of MAYE. Fourth, in many settings like school, youth are accustomed to being differential to adults. We are asking youth themselves and the adults working in partnership with them to undo the traditional ways of interacting with one another. This one may take time, but is essential to fully operationalizing MAYE. Finally, MAYE is second nature to some organizations, and it's baked into their organizational standard operating procedures. For others, MAYE is a new era of exploration. To the extent that more experienced organizations can mentor less experienced organizations, we would all benefit from dedicated space for dialogue on MAYE. After all, it is an interactive process that is continually revisited. Today's session will not cover all of these aspects of what it takes to operationalize MAYE, but MPHD, and likely many of you listening today, are working to make sure your organizations and projects have these elements in place to realize meaningful adolescent and youth engagement. Today, you will hear 3 speakers present on MPHD activities that put MAYE principles into practice. Ibrahim Traore, Youth Programs Coordinator, MPHD Mali, will speak about partnering with the network of young ambassadors to build their workforce and leadership capacity. Louisa Pulani, Deputy Head of Reproductive Health, PSI Malawi, will speak about developing social and behavioral change materials in an intentional way that respects and values the contributions of youth. Noel Adanlo, FPRH and HIV advisor of MPHD Benin, will speak about integrating young people's ideas and perspectives into development of the Tata Ani chatbot. I will now hand it over to Ibrahima to share about the work MPHD is doing in Mali, partnering with Network of Young Ambassadors. This presentation will come in French, and from here, some part of the presentation will be in French and some in English. Be sure you have selected the interpretation language you wish to hear. That interpretation button should be found at the bottom of your screen in Zoom. And now over to you, Noel. Over to you, Ibrahima.
Merci beaucoup, Nina Chalita, de m'avoir passé la parole. Tout d'abord, je vous salue tous très respectueusement pour l'attention que vous portez à ce webinaire. C'est un réel plaisir pour moi de partager avec vous la collaboration qui était inscrite avec le réseau des jeunes ambassadeurs et MPHD. Juste un gentil rappel à tous ceux qui parlent uniquement anglais de ne pas oublier de choisir les langues de préférence. Alors, je vais demander gentiment à Alexandra que chaque fois que je veux qu'elle aille au slide suivant, au diapo suivant, je vais dire « Vive la jeunesse » au lieu de dire « diapo ». On en a beaucoup entendu. Merci d'avance. Tout d'abord, il est utile pour moi de parler un peu de la problématique de la santé des adolescents et des jeunes du Mali avant de commencer. Sachez qu'au Mali, ici, parler de la sexualité entre jeunes et adultes est un sujet tabou. Les jeunes reçoivent moins d'informations sur leur santé alors qu'ils pratiquent très tôt la sexualité. Vous imaginez les risques que peut courir un jeune ou un adolescent qui pratique la sexualité alors qu'il n'a pas encore suffisamment d'informations sur sa santé, sur son corps, ses fonctions et son fonctionnement. Environ la moitié des complications liées à la grossesse et à l'accouchement surviennent chez les adolescents et les jeunes de 10 à 24 ans. Plus de 58% des filles et des femmes déclarent avoir eu des rapports sexuels avant l'âge de 18 ans. Mais l'utilisation des contraceptifs modernes chez les jeunes est faible. 6% pour les jeunes filles âgées de 15 à 19 ans, 11% pour les jeunes âgés de 20 à 24 ans. Toutes ces informations sont issues de l'EDS, qui est l'étude démographique sur la santé 5 du Mali, bien que nous savons qu'il existe actuellement l'EDS 6, mais nous avons constaté qu'il n'y a pas une différence considérable, raison pour laquelle nous avons retenu ces mêmes données. Selon nos constats et selon les expériences que nous voyons sur le terrain, les cliniques privées et les pharmacies peuvent beaucoup aider les jeunes à obtenir des soins privés et sans jugement qu'ils désirent. Le travail du MPHD avec le secteur public est limité en raison de la situation politique actuelle au Mali que beaucoup d'entre vous savez. Vive la jeunesse. Engager le réseau des jeunes ambassadeurs SRPF. D'abord, je profite ici pour donner un grand merci à tous les acteurs qui travaillent dans MPHD pour la cause des adolescents et des jeunes. Nous le voyons chaque jour, le respect avec lequel vous traitez les jeunes, et c'est une occasion d'en parler. La jeunesse, c'est aussi un état d'esprit. Aujourd'hui, il y a un grand partenariat dynamique entre MPHD et le réseau des jeunes ambassadeurs. D'abord, permettez-moi de vous parler, c'est quoi le réseau des jeunes ambassadeurs? Le réseau des jeunes ambassadeurs, c'est un mouvement de jeunes engagés pour la santé de la reproduction et la planification familiale des adolescents et des jeunes au Mali. Ce réseau est composé de jeunes filles, de jeunes garçons âgés de 15 à 30 ans. Parmi ces jeunes ambassadeurs, il y a des jeunes scolarisés, non scolarisés. Ils sont représentés dans toutes les régions du Mali. Ce réseau est né lors d'une des grandes réunions du partenariat de Ouagadougou, que beaucoup d'entre vous savez. Et dans chacun des 9 pays du partenariat de Ouagadougou, il y a un réseau de jeunes ambassadeurs. Le rôle des jeunes ambassadeurs est de créer des contenus pour les médias sociaux, notamment Facebook, Twitter, Instagram et les autres applications de discussion comme WhatsApp. D'utiliser les réseaux en ligne pour sensibiliser les jeunes et de plaider pour les services de planification familiale adaptés aux jeunes dans tout le Mali. Aujourd'hui, ce réseau est connu dans les pays par toutes les organisations qui œuvrent dans le domaine de la santé de la reproduction, y compris le niveau national. Vive la jeunesse. Merci beaucoup à mes prédécesseurs d'avoir introduit avec l'approche maillée, engagement significatif des adolescents et des jeunes, qui est même le thème de ce webinaire. L'engagement significatif des adolescents et des jeunes, les jeunes l'ont plusieurs fois dit, tout ce que vous faites pour nous, sans nous, est contre nous. Fin de citation. Cette approche, c'est un partenariat inclusif, intentionnel, mutuellement respectueux entre les jeunes et les adultes. Grâce à cette approche, le pouvoir est partagé. Les contributions respectives sont valorisées et les idées, perspectives, compétences et forces des jeunes sont intégrées dans la planification, dans la conception et dans la mise en œuvre des programmes. L'approche maillée reconnaît les jeunes en tant qu'experts de leurs propres besoins et priorités, tout en renforçant leur capacité de leadership et de travail. Un PhD travaille dans ce sens et toute l'équipe de MPHD est à l'aise avec cette approche. Un bureau même est réservé pour les jeunes ambassadeurs dans chacune des régions où il y a un bureau PC ici. C'est là pour qu'ils puissent travailler à l'aise, pour qu'ils puissent avoir accès à l'Internet et pouvoir tenir les réunions périodiques sans problème. Ce webinaire est même une preuve que d'ici quelques mois, plusieurs autres succès de collaboration avec les jeunes à travers l'approche maillée, grâce à l'approche maillée, feront l'objet de discussions. Vive la jeunesse. Renforcer la capacité de leadership des jeunes ambassadeurs. MPHD renforce la capacité du réseau des jeunes ambassadeurs dans le but de renforcer l'accès des jeunes aux services de santé essentiels, de mobiliser les jeunes pour défendre leurs droits et de contribuer au plan d'action national du Mali pour la planification familiale. Un PhD développe la capacité organisationnelle de ces réseaux, dirigés par des jeunes, afin qu'ils deviennent une organisation autonome grâce à son soutien en matière de gestion de projets, de communication, de conception, de mise en œuvre et d'évaluation de programmes. Vive la jeunesse. Renforcer la capacité de leadership des jeunes ambassadeurs. Dans ce partenariat avec les jeunes ambassadeurs prennent en charge toutes les décisions qui les concernent. Ils proposent les activités et élaborent leur plan de travail. Le réseau a commencé tout d'abord par organiser un grand atelier afin d'élaborer son plan de communication et a ensuite lancé sa toute première grande campagne dénommée Kenya Yalaba. Alors, Kenya Yalaba est un terme bambara qui veut tout simplement dire la grande balade santé. Cette campagne visait à atteindre les jeunes et les femmes, y compris les plus marginalisés, c'est-à-dire les travailleuses de sexe, ceux qui vivent dans les zones minières, avec des informations et des services de santé de la reproduction et de la planification familiale. Cette grande campagne de sensibilisation était couplée à l'offre de services, SRPF, à travers 2 cliniques mobiles mobilisées. Plusieurs localités qui ont des accès difficiles ont été sillonnées afin de sensibiliser les jeunes, pas seulement, et aussi offrir en même temps des services de santé de la reproduction et de planification familiale. La campagne comprenait des sessions de sensibilisation avec la poésie des jeunes, des slammers, du rap et d'autres divertissements. Tout ceci dans le but d'attirer les jeunes à s'intéresser à la campagne. Un grand succès a été enregistré. Plus de 600 000 jeunes étaient touchés en information sur la santé de la reproduction et la planification familiale à travers les radios, à travers Facebook, Twitter. Plus de 1575 adolescents et jeunes sont touchés en information et plus de 525 ont été référés vers les cliniques privées MPHD à travers des cartes de référence qu'ils ont à disposition. Et cela à travers des causeries éducatives et des émissions radio qu'ils ont organisées dans toutes les régions et dans tous les quartiers. Plus de 1000 jeunes femmes ont reçu des services de planification familiale, y compris le dépistage du cancer du col de l'utérus, dans les 2 cliniques mobiles qui avaient été mobilisées. De nombreux autres ont été orientés vers les cliniques MPHD, des cliniques privées qui sont représentées dans toutes les régions du Mali. 90 hommes et 158 femmes, tous des jeunes, ont appelé la ligne d'assistance téléphonique à travers notre ligne verte qu'on appelle Keneako. C'est une ligne verte qui est là pour donner des informations à la population sur la santé de la reproduction et pour donner les orientations, les orientations géographiques des cliniques privées MPHD qui se trouvent dans les différentes localités. Et en plus de tout ceci, plus de 42 000 condoms masculins ont été distribués à travers cette campagne. Il faut le dire, cette campagne a été un grand succès. Il y a des vidéos et des images que nous avons. Et je rappelle que toutes ces vidéos et ces images ont été prises par les jeunes ambassadeurs eux-mêmes, ont été montées par eux-mêmes. Et ces vidéos témoignent la joie de la population qui a bénéficié de ces services et aussi des messages que ces bénéficiaires ont adressés aux bailleurs. Et je pense que c'est très intéressant de visionner ces vidéos. Alors, les jeunes m'ont chargé de vous dire à travers ce webinaire un grand merci pour tous les efforts que MPHD est en train de mener en faveur de la jeunesse. Vive la jeunesse! Alors, quelles sont les prochaines étapes? Tout d'abord, nous souhaitons, dans ce partenariat, dans les jours à venir, développer un programme de stage en rotation pour les jeunes ambassadeurs dans les différents départements de PSI afin de renforcer les capacités du réseau en matière de main-d'œuvre. Car parmi les jeunes ambassadeurs, il y a des étudiants, il y a des diplômés sans emploi et nous pensons que ces stages vont contribuer à renforcer leurs connaissances, leurs compétences et surtout leur leadership. Deuxièmement, dans un avenir proche, nous comptons élaborer des solutions dirigées par les jeunes pour créer un environnement favorable aux jeunes dans les cliniques du secteur privé, afin que les jeunes puissent se sentir inclus, ils se sentent à l'aise et le bienvenu dans les cliniques privées. C'est-à-dire avoir des cliniques privées MPHD dans chacune des cliniques MPHD, un espace spécifique aux jeunes où ils peuvent échanger, se sentir à l'aise et peuvent trouver des jeux, des journaux et des informations sûres et échanger directement avec les prestataires de santé. Une considération clé à noter, prévoir dès le début comment les activités de maillet peuvent affecter le budget global. Et je vous remercie. Vive la jeunesse et nous restons disponibles pour toutes les questions. Nina Shalita, merci de m'avoir donné la parole. Je vous retourne la parole.
Merci beaucoup, Ibrahima. Thank you so much, Ibrahima. I'll remind participants to please go ahead and put any questions they have for Ibrahima and the experience shared in Mali into the chat now. We'll note down your questions and we'll look at them together after the 3 country presentations. We welcome the questions to be typed in English or in French. Now I pass it over to Louisa Pulani in Malawi to share about their engagement of young people in Malawi. Over to you. Thanks, Louisa.
Thank you so much. I think you can go to the next slide. Hello. Yeah, so this presentation mainly will look at some of the demand creation activities that we focused on adolescents and youth. So we should look at the context of Malawi in terms of young people and adolescents. So in Malawi, we have the age at first, sex for both girls and boys, being 13% for girls, as well as for boys being 15%, and 22% of boys having first sex before the age of 15. And then the birth rate among adolescent girls is high, with 136 births per 1,000 girls. I'm trying to remove this, yeah. Then many young people discontinue their education. During primary school, we have 22% of girls discontinuing education during primary school. And then we have 40% of males and females discontinuing education during secondary school education. And the main reasons usually are due to marriage or pregnancy. So while the DHS does not disaggregate family planning source by age of user, it estimates that almost 20% of all women aged 15 to 19 receive their modern method from private sector sources. So this information, we got it from the DHS 2016. But despite these statistics, young people in Malawi are still reluctant to access contraceptives, and they usually cite lack of privacy and confidentiality at private facilities, which are designated to be youth-friendly health service provider or provision service delivery points. And most young people, therefore, would prefer a limited human contact when accessing sexual reproductive health information and services. The private sector, therefore, will play a very crucial role as it provides a perceived conducive environment for non-judgmental, youth-friendly health services. Next slide, please. So as you saw from the previous slide, young people really have a great need for tailored social and behavior change communication materials. What we noted was that usually when we're coming up with programs, we design programs for the youth. That's why at the end of the day, those programs, they don't work. They don't give us the impact that we want to give because we design the programs for the youth. So MPHD, what we did was to try as much as possible to come up with tailored social and behavior change communication materials. And we had our 2 goals where we wanted to engage young people between 10 to 24 in social behavior change activities aimed at increasing youth demand for family planning, as well as reproductive health services. Then we also wanted to rely on the human-centered design process to develop tailored family planning and reproductive health messages. We really wanted young people to participate. So our approaches basically was to engage young people in private sector, because we really wanted to come up with something very attractive that would reach young people even in the rural setting. Then we also incorporated private providers in the design process. So we also tried to engage influencers of youth behavior, including the parents, including the community leaders, the providers from the private sector, as well as the Ministry of Health providers in the process of formative research, because we really wanted to gather insights that would really respond to young people's needs in terms of information as well as service delivery. So we used the youth from private sector because we know that youth from private sector are very much engaged in terms of coming up with very attractive products as requested by the mass youth that we work with in the rural areas. So this approach then led us to come up with two solutions according to what is on the slide. We have Meet the Expert video series, and then we also have a comic book. And the video was aired on television and through social media. And the comic book was distributed through various channels like the Youth Open Days. We also distributed through our in-school program activities, and even the youth clubs that we are working with. But these prototypes now are complementing the work of our interpersonal communication agents to be able to refer young people to PSI mobile outreach clinics, though they still have that right to access services everywhere they would like to access, including the private sector. Next slide, please. So in the next few slides, I'll walk you through these materials in greater depth. We have this definition of Maye. Sorry, I'll read it as Maye. You've seen this slide before. So while our approach addressed several aspects of Maye at once, in this presentation, I'll focus on how we in Malawi focused on intentionality in our approach, as well as valuing the respective contributions of young people. So here we're looking at the intentional part as well as the respective contribution. Next slide, please. So under respective contributions of young people, we had a discussion with young people, and here young people provided insights on content which they wanted to be included in our SBC materials. And from these interactions, what we did was we had to divide the team that came to these meetings or to these workshops. We had to divide the boys to be in their own group, and then the girls to be in their own group, and then the social influencers like parents, community leaders, and other, as I've already mentioned, to be also in their own groups as necessary. So from the boys, what we got was that boys aged to 24 do not see contraception as their responsibility. They believe that family planning is for girls because they're the ones that become pregnant. So the video series that we came up with addresses this concern while integrating humor and drama, and giving that information to the boys to say, no, everybody has the responsibility to get or to access family planning services. We also worked with married and unmarried girls aged 15 to 24 who expressed a desire to achieve success and crave information on how to prevent pregnancy while at school. So what we got was that girls, they really want to continue school, they really want to achieve their goals in life, but they have this challenge where they have this risk of unprotected sex. So they couldn't really relate to say being a girl in school would be able to access family planning or contraceptives. So what we're trying to address was that even a girl, even a young woman, unmarried woman, or even a married woman who goes back to school can be able to access family planning services despite the marital status. So we managed to address that through the comic book. And then what we noted was that male and female youth express hesitancy in visiting public sector due to that lack of perceived confidentiality. They say people from the public sector, they do talk a lot with their parents, with other influencers. So we also included the private sector deliberately. Can you go to the next slide? Yeah, we deliberately included the private sector because, as I said, that we usually work with young people in the rural setting where we implement our programming. But what we noted that the rural youth, they have challenges taking the content that they want to talk about, that they want to be addressed, to come up with something attractive that would entice them to, like, for example, to listen more to the TV because they don't have that experience. So we really wanted to work with young people from the private sector to help in designing the content for videos and comic book. So in terms of intentionality as well, in prototype development, we got separate uh, ideas from girls and boys. We had different life stages that were recognized. Girls and boys, they expressed preferences for different communication channels. And we had boys, they really wanted video series. And girls, they wanted that comic booklet where they would want to talk about their challenges, but at the same time, trying to achieve their goals in terms of completing their school, that is primary as well as secondary school. So the video and comic book content tailored to respond to different needs of boys and girls. And here we're mainly working with girls and boys within the 15 to 19 years. We also tried to include the video that was featuring the private sector clinic, because we really wanted these young people to understand that if they are comfortable to access services, SRHA, as well as family planning services from public sector, they can even access these services from private sector, where they already indicated to say they are less judgmental, as well as they give that confidentiality to the youth. So we will deliberately featured the private sector clinic to address this. So the comic book focused, as I've already talked about, the challenges that girls face and how they can negotiate to say they can combine, they can go to school, they can access family planning methods, while at the same time trying to achieve what they want to get at the end of their professional growth. Next slide, please. So here we're looking at the penetration of Sbcc materials. So we have, I'll keep repeating, apologies. We had the video series, that is the Togolola 2. That is the first picture that you can see that is on top. Then we had the comic booklet that is down there. It talks about Karma and her friends. And we managed to penetrate through Facebook, YouTube, and the ladder to success. This is the booklet, was distributed through the open days, and we managed to distribute 5,000 copies through the youth clubs, through the schools, through the open days. And we also conducted, we had a U report, which was done, I think, in February, where we really wanted to see which channels young people usually prefer when accessing information on sexual reproductive health as well as family planning. And we worked in 8 districts and we had selected youth clubs. We didn't work in all the youth clubs, but we had selected youth clubs. And 18% of the young people reported exposure to the comic book. So the measures that are shown here are on how our SBC materials have penetrated television and various social media channels. So our presentation, this presentation today, addresses only one activity and its related measures. But we have other activities that are already happening in parallel with the measures. So we do provide outreach mobile clinics where we have our teams providing services in the hard to reach areas. And we also have youth-led specific outreach clinics where the young people are able to access sexual reproductive health as well as family planning services. But for in this presentation, I'll just focus on the SBC materials and how the penetration happened. So despite this, we also acknowledge that our measures don't address youth engagement itself, but we believe that we can build upon the sample Mayan indicators included in the SPG guide, and we would want to even integrate new measures to help ensure that we hold ourselves accountable, that at the end of the day, we should make sure that we are really implementing the MAYE principles as indicated in the SPG guide. Next slide, please. So our future consideration regarding MAYE, our approach to MAYE is something that we are constantly revisiting and refining. It's a flexible program, and we are taking this consideration into account for the future. So we really want to integrate young people's perspectives, because we want them to be engaged, to be intentional, to be leaders. So young people, they would really want to see an additional video series following this one. And all things being equal, if we have adequate funding, we'll be able to work on this. And we also want to build on young people's leadership capacity, where we really want to sustain engagement in youth-led family planning demand generation through youth clubs. We've started doing this, but we really need support on that. And we also want to amplify youth engagement into family planning private service delivery through the introduction of social accountable practices. So we have included this in our upcoming work plan. So all things being equal, we'll be able to implement this amplification of youth engagement in family planning private service delivery through the social accountability practices. So our goal is to prepare young people to take on leadership role, and we really want to explore how to engage young people in social accountability, which is one way that we can ensure that MAYE approaches become sustainable rather than once-off engagements. So our key consideration is that through implementation, we have to serve like two loads. We have the donor, we have the priorities that are in the program, and also we have the priorities that are coming from the youth themselves. So the difficulty we have is operationalizing MAYE, especially balancing the contributions of youth with the needs of the project. So we have the youth that have their needs, and then we also have the project that has its own needs. So this sometimes we just have to do the trade-offs. For example, young people in this case scenario, they told us that they would like a comic book to address the theme of sugar daddies. They said, oh, you know what? We are poor. We find this man who is older than us, who is ready to support us. Can you talk about that in the comic books? But we couldn't do that because we also had to prioritize other content that more or less closely matched with the scope of the project. And that's why now we had to choose to say, okay, let's look at this girl who really wants to go to school, but she also has to access family planning methods, which to them, they believe it can't work. A girl shouldn't access family planning method. Even the social influencers, they say a girl at school shouldn't focus on family planning methods. So we had to choose which one is more or less closer to the project scope. So we had to look at this girl now accessing family planning methods while at school. So that is that key consideration, that where we would like to align youth interests in content with the project scope. Next slide, and I think this is the last one. Thank you so much. Over to you.
Louisa, thank you very much. We've now had two different examples from Mali and from Malawi on the ways in which they are operationalizing MAI or MAYE. A reminder again to put any questions you have into the Zoom chat box, please. And now for a final example of operationalizing MAYE or MAI will come from Noel Adano in Benin, sharing about their work on a digital intervention. Over to you, Noel. Thank you.
Merci beaucoup, Nina, pour la présentation et de ce webinaire pour parler des activités de l'ABMS PSI Bénin dans le cadre du projet MPHD financé par l'USAID au Bénin. Aujourd'hui, nous allons nous focaliser sur l'application de l'approche MAI dans la conception de notre chatbot, le chatbot Tata Annie. Il faut dire que ce chatbot est une activité du partenariat entre MPHD et l'ABMS PSI Bénin. Et avant de commencer ma présentation, je vais vous présenter un peu la situation de la santé de reproduction au niveau des jeunes au Bénin. Slide. Le Bénin est un pays de l'Afrique de l'Ouest qui a une population majoritairement jeune. 45% de la population a moins de 15 ans et parmi les 15 à 19 ans, 20% des filles ont eu une ou plusieurs naissances. Le manque d'accès aux connaissances sur les menstruations et aux produits d'hygiène menstruelle peuvent être source de peur, d'embarras ou de honte. Ce qui fait que 11% du taux d'abandon des classes au niveau des filles, bien sûr, est dû aux menstrues. 66% des filles ne sont pas informées sur les menstrues et la gestion jusqu'à l'apparition des premières règles. Et les adolescentes qui sont non mariées et les jeunes femmes de 15 à 24 ans ont un besoin non satisfait très élevé en matière de contraception, ce qui est estimé à 60,8%. Slide. Pour répondre aux besoins des jeunes en matière d'informations fiables sur les thématiques de la santé, de reproduction et spécifiquement la contraception, l'ABMS PSI Bénin a développé dans le cadre du projet MPHD, comme je le disais, le chatbot Tata Annie, qui est une innovation technologique, bien sûr, basée sur l'utilisation de l'intelligence artificielle conversationnelle pour fournir aux utilisateurs les informations dont ils ont besoin. Cette innovation s'appuie sur des approches commerciales du secteur privé, comme par exemple l'implication des associations de jeunes, des agents de santé du secteur privé et les groupements de femmes pour atteindre des utilisateurs et promouvoir cette solution innovante. Tata Annie fournit aux jeunes des informations sur la santé de reproduction et la planification familiale de manière pratique. Et Tata Annie est accessible de façon instantanée, sécurisée et confidentielle à l'aide d'un algorithme et d'une série de questions très dynamiques. Tata Annie peut également mettre les utilisateurs en relation avec une conseillère en ligne, dans le cas d'espèce, une sage-femme certifiée disponible pour répondre aux questions 24 heures sur 24. Alors, il a intégré à ce chatbot Tata Annie un système de référencement qui permet à l'utilisateur de trouver en fonction de sa position les cliniques de la franchise de réseau de cliniques privées partenaires sur le projet MPHD et les centres jeunes Amour et Vie, qui est proche de ce utilisateur en fonction de sa position géographique pour prendre un rendez-vous ou pour aller bénéficier d'un service. Je parlais tout à l'heure des centres jeunes Amour et Vie. Ici, ces centres jeunes Amour et Vie sont des centres conviviaux qui offrent des services de santé qui sont adaptés aux jeunes et c'est une initiative de l'ABMS PSI qui est porté par son programme Amour et Vie, qui est un programme jeune qui œuvre pour l'amélioration de la santé sexuelle et reproductive des adolescents et jeunes. Amour et Vie a également des pôles de jeunes et une stratégie social média qu'il anime au quotidien. Slide. L'inclusivité qui encourage une approche très participative et engageante des jeunes a été vraiment respectée au cours de la conception de cette solution numérique dont je vous parlais tout à l'heure. Son amélioration et sa promotion, qui est toujours en cours d'ailleurs, dans le processus depuis sa création jusqu'à la promotion qui est en cours. Tout le processus de création s'est basé sur des orientations de l'approche MAE, sauf la partie technique, bien sûr, qui a été gérée par des experts en la matière. Lorsque nous prenons par exemple le nom Tata Annie, la silhouette, la posture que vous allez voir tout à l'heure et d'autres éléments, ces éléments ont été proposés et validés par les jeunes qui ont été tout le temps consultés et impliqués dans tout le processus, soit individuellement ou à travers des mouvements d'action de jeunes et de femmes jusqu'à la promotion qui se fait actuellement, comme je le disais. Pour la petite histoire, les jeunes ont préféré, par exemple, dire Tata parce que dans le jargon jeune ici au Bénin, c'est Tata qui désigne des agents de santé qui sont aussi des jeunes, qui sont des complices de leurs clients, qui sont jeunes et offrent des services de santé adaptés. Puisque nous avons le défi de temps aujourd'hui, je vais me focaliser sur deux aspects de l'utilisation de l'approche MAE, c'est-à-dire l'implication et l'engagement des jeunes dans la mise en œuvre de la solution numérique Tata Annie. Slide. Le premier aspect que je vais aborder ici est la participation et l'implication des jeunes dans le processus du choix des thématiques abordées par le chatbot Tata Annie. Les chiffres que j'ai montrés un peu plus haut dans le contexte et les statistiques au niveau national montrent que les jeunes ont besoin d'informations en matière de santé sexuelle. Ces statistiques ont été confirmées par les jeunes Amour et Vie qui ont proposé la thématique de l'hygiène menstruelle et les méthodes contraceptives. Les pigistes Amour et Vie, bien sûr, ont également eu recours à des membres des unités scolaires Amour et Vie pour le choix et la validation de ces deux thématiques qui sont abordées actuellement dans le chatbot Tata Annie. Après cette étape, ces propositions de thématiques ont été encore confirmées par la stratégie sociale média dont je parlais tout à l'heure, jeune de l'ABMS. Et au niveau de cette stratégie-là, la majorité des préoccupations qui sont envoyées et traitées par les réseaux sociaux abordent des questions, des règles et les méthodes contraceptives. Slide. Le deuxième aspect que je veux aborder est l'implication et la participation active des jeunes dans le processus de testing et l'amélioration du chatbot Tata Annie. Alors, une quarantaine de jeunes pigistes Amour et Vie et membres des unités scolaires Amour et Vie ont porté la voix de leur père, que ce soit individuellement ou en groupe, lors du testing de la première version de cette application du chatbot Tata Annie. Ceci leur a permis de constater que certains adolescents et jeunes utilisent des téléphones ou des terminaux non intelligents ou des smartphones, par exemple, qui n'ont pas assez d'espace pour accéder à Facebook, qui juste là était quand même la seule option pour pouvoir utiliser cette solution numérique-là, puisque c'était hébergé au départ au niveau de Facebook Messenger. Ils ont donc recommandé, je parle bien sûr des jeunes, de créer des options pouvant permettre aux adolescents et jeunes n'ayant pas de compte Facebook, par exemple, de discuter avec le chatbot Tata Annie, ce qui a permis de penser très rapidement à l'extension vers WhatsApp et microsites, ce qui est d'ailleurs une réalité depuis quelques semaines. Ils ont aussi proposé de lier le chatbot à des agents de santé pour discuter en direct avec les utilisateurs lorsque le chatbot n'est plus en mesure de répondre à une préoccupation ou lorsque la préoccupation la réponse à cette préoccupation n'est pas programmée au niveau du chatbot, ce qui a été fait. Ils ont aussi proposé de développer une option pour accéder aux informations sur les centres de référencement qui sont intégrés au niveau du chatbot plus proche de chez eux par des mots, c'est-à-dire les tests secondairement à la géolocalisation qui était initialement intégrée à l'application. Sans oublier, bien sûr, la reformulation de certaines phrases dans l'algorithme du chatbot et la contextualisation même de certaines expressions et mots que les jeunes ont quand même eu à apporter au niveau du contenu de Tata Annie. Donc, comme vous le voyez au niveau de la diapositive, il y a les 3 possibilités que les jeunes ont aujourd'hui pour pouvoir accéder au chatbot Tata Annie, pour pouvoir commencer la discussion qui est sécurisée avec Tata Annie. Facebook Messenger, WhatsApp ou un site web comme ils l'ont souhaité. Slide suivant. De octobre 2021 à début septembre 2022, le chatbot Tata Annie a enregistré plus de 10 000 utilisateurs uniques. On parle ici d'utilisateurs uniques puisque les utilisateurs sont comptabilisés une seule fois à la première connexion. Et comme vous pouvez le voir, ces utilisateurs sont répartis un peu partout au Bénin. Et nous avons quand même fait des captures d'écran du dashboard qui nous permet de suivre et d'analyser en temps réel les données qui sont enregistrées au niveau de cette innovation technologique chatbot Tata Annie. Comme vous le voyez toujours à l'écran, les jeunes de la tranche de 20 à 24 ans constituent en majorité les utilisateurs. Cette tranche d'âge représente plus de 55% du nombre total d'utilisateurs uniques. Et Parakou, qui est une ville du septentrion, qui est à plus de 400 km de la capitale, qui abrite aussi une équipe de jeunes pigistes, de jeunes volontaires, vient en tête en termes de nombre d'utilisateurs. Cela confirme donc le fait que plusieurs associations, plusieurs mouvements de jeunes participent à la promotion de cette solution numérique. Les données que vous voyez ici au niveau de cette diapositive concernent la portée et l'utilisation du chatbot lui-même. Nous n'avons pas ici des statistiques sur l'utilisation des services par les jeunes. Bien que nous puissions effectuer un certain suivi des référencements via le chatbot, nous n'avons pas encore quand même pu développer un moyen complet pour pouvoir suivre l'itinéraire de ces références que le chatbot fait vers les centres jeunes amour et vie ou les cliniques privées partenaires sur le projet MPHD. Donc, c'est quelque chose, c'est un outil numérique, par exemple, une option qu'on pourrait explorer dans l'avenir. Slide. Vous comprenez donc avec moi que si nous avions pu obtenir ces résultats que je vous ai présentés, c'est parce que les jeunes se retrouvent à travers Tata Annie et contribuent même pour son amélioration. C'est pour cela qu'en termes de perspective, nous comptons déjà impliquer davantage les jeunes pour adapter le chatbot, l'améliorer et garder ce chatbot là pertinent pour eux, en rassemblant et en utilisant d'autres idées et perspectives que ces jeunes-là pourront nous fournir et pourquoi pas aussi renforcer les capacités de ces jeunes pour que désormais eux-mêmes soient en mesure d'analyser eux-mêmes ces données, les données du chatbot et même participer à la partie technique qui est le développement en faisant de ces jeunes-là des développeurs, c'est-à-dire en renforçant leurs capacités. Nous comptons également augmenter l'inclusivité à travers la traduction, par exemple, dans d'autres langues locales, qui sont des options aussi qu'on pourrait intégrer avec le temps à notre solution numérique. Je vais finir ma présentation avec une considération qui est un défi majeur pour la réussite de l'approche MAE, qui est de faire correspondre la demande très souvent, qui est souvent impatiente des jeunes, avec des délais qui sont plus longs, c'est-à-dire lorsqu'on tient compte des réalités, des projets que nous exécutons. Merci beaucoup pour l'attention. Je te retourne la parole, Nina.
Merci beaucoup, Noel. Thank you, Noel, and thank you so far. Now we've all our presenters and to the participants and for many interesting questions we have seen and shared in the chat so far. Please continue to add any questions into the chat box. At this point, we've heard 3 compelling examples of using MAYE alongside private sector actors from Mali. We've heard about partnerships with civil society, network of youth leads or ambassadors. From Malawi, we've heard about content co-creation activities that bring youth and private sector representatives together. And from Benin, we've heard about how youth have been involved in the development of a chatbot that pulls upon commercial private sector practices. Before moving into Q&A, let's first acknowledge that this is hard work. Using MAE is not without challenges. In the private sector, the dichotomy that exists between what the private sector prioritizes, such as profit or access to new medical learning and technology, and what youth prioritize can be difficult to balance. MAE can also be difficult to measure, something that was touched on or alluded to by a couple of our presenters. While measuring reach is often achievable, linking MAE efforts to service uptake among youth or measuring engagement itself is not easily tracked or attributed through, though as a place to start, I will note that the MAE strategic planning guide does provide some illustrative indicators. As we turn to Q&A section of this webinar, we know we won't be able to definitely solve these broad, tough issues today. But we do hope that comments you'll have shared in the chat will spark discussion and ideas on how we, as a community, can begin to tackle some of the MAE's biggest questions, and from there create clearer paths to operationalizing MAE widely. So let's get to these questions. We'll start with a couple of questions I'll pose to each of our 3 presenters. Next. Knowing that the private sector is a key part of MPHD's approach, I want to start with this question. As Momentum private healthcare delivery activities, what unique considerations did you encounter using MAE within the private sector or with private sector actors? En tant qu'activité de Momentum private healthcare delivery, quelles considérations uniques avez-vous rencontrées en utilisant MAE au sein du secteur privé ou avec des acteurs du secteur privé? Why don't we hear from Ibrahim, and then Noel, and finally Louisa. Ibrahim, vous avez compris la question?
Oui, merci encore Nina Shalita. Ce que nous pouvons considérer comme acquis avec le secteur privé, les cliniques privées, qui est très important, c'est l'engagement des prestataires de santé de ces structures-là. Et très souvent, les prestataires de ces structures sont aussi les promoteurs de ces cliniques. Et ils sont engagés à pouvoir accompagner les jeunes. Et ça, c'est un acquis. Et surtout, dans le cas de MAE, l'objectif de MPHD qui est de créer un cadre, un environnement favorable pour les jeunes dans ces cliniques privées. Donc, les prestataires et les promoteurs des structures privées acceptent facilement qu'il y ait une création d'espace ou d'un environnement dédié spécifiquement aux jeunes. Ça, c'est un aspect très, très important. Le second aspect, ça, c'est par rapport à la qualité des services. Et les cliniques privées sont, comme on le sait, toujours plus chères que les structures publiques. Mais quand vous voyez que la population se dirige vers ces structures, c'est qu'il y a quelque chose qui est vraiment meilleur que dans les autres structures. Donc, la qualité des soins aussi peut être considérée comme un point important pour les jeunes. Parce qu'il faut le reconnaître, les jeunes sont vraiment exigeants dans les services qui leur sont donnés. Merci, je vous retourne la parole.
Merci beaucoup. Je vais vous demander d'essayer de parler, de reprendre très court parce qu'on n'a pas beaucoup de temps qui reste. I also request that as we ask these questions, you try to be as brief as possible so that we're able to finish within time. Noël, s'il vous plaît. Noël, can you please answer the question? Vous avez compris la question?
Oui, j'ai compris la question.
Merci, Noël.
Voilà. Pour répondre à cette question, il faut déjà dire que le projet MPHD travaille spécifiquement avec le secteur privé. Et dans la mise en œuvre de l'approche MAE, nous avions quand même eu des défis et avantages. Nous pouvons déjà parler de la motivation des jeunes à collaborer, ce qui a été un grand succès pour nous. Cela s'explique par la participation active de ces jeunes-là qui se sentent vraiment impliqués et cela favorise la mise en œuvre. Il faut aussi noter que la structuration du secteur privé avec la plateforme du secteur sanitaire privé au Bénin est un avantage pour nous dans la réalisation de MAE. Et il n'y a pas, lorsqu'on prend le privé, il n'y a pas beaucoup de barrières administratives. Alors, on peut dire que c'est possible de mettre MAE en action. Merci.
Merci, Noël. Finally, Louisa.
All right, thank you. So my response to that question is that, you know, young people are really motivated to seek services in the private sector, and that is very evident. But the cost and financial implications have to be taken into account when linking young people to private sector. You know, the private sector would like to get a profit out of that, but our youth, the ones that we work with mostly under MPHD, have financial limitations. So it's really difficult for them to access services from these private sector facilities, even including pharmacies and everything. Thank you.
Thank you very, very much, Louisa. Before moving on to our second question for the presenters, we'd like to launch one more poll so we can hear from the audience. The question should pop up on your screen. Do you agree or disagree with the following statement? MAE is easy to operationalize. Please cast your vote for either agree or disagree. Okay, thank you for voting. I see many of you responded that you disagree and that it isn't always easy to operationalize MAE. I think many with rich experience in MAE, including our presenters, would agree, which leads us to our next question. We only have 2 minutes left. Let's see what we can do within the few minutes. I'm not sure we will have time for the questions and draft response, but we'll see how far we've gone. Let's just go to the next and see. Next, please. With this next question, I'd like to focus on challenges. Challenges are inevitable, and we know they can be great opportunities that urge us to pivot and make course corrections as we go. I want to share some observations on types of challenges we hear about. Challenges can relate to time and resources, state of evidence and lies effectiveness. That which is not required is often not measured. Biases against young people's age or expertise, lack of systematic implementation, and also lack of motivation or interest from others. So now we pose a question on challenges to our presenters. Maybe I'll just, if we are just losing time, but maybe I can ask any of the presenters who can ask. There are a number of persistent challenges that programs often face when using MAI. What was one challenge you faced and how have you been able to address these challenges? C'est qui veut répondre? Ibrahima, OK.
Oui, merci. Très rapidement, je vais parler de deux défis importants. Le premier, c'est par rapport au coût des méthodes contraceptives. Les jeunes ambassadeurs mènent beaucoup d'activités de sensibilisation et réfèrent les jeunes à aller bénéficier des services. Et souvent, les jeunes sont confrontés au coût, n'arrivent pas à payer certaines méthodes qu'ils préfèrent. Donc ça, c'est un premier défi. Le second, c'est par rapport à la stabilité des prestataires qui sont dédiés aux jeunes dans les cliniques privées. Le promoteur désigne un prestataire à s'occuper des jeunes. Il est formé en service de santé adapté aux jeunes et il change plusieurs fois avec les jeunes et à cause des raisons professionnelles, il quitte pour aller ailleurs. Ça aussi, c'est un défi. Je vous remercie.
Merci, Ibrahim. I would like to request that the mic is muted.
Different with us. Now also
I would like to request that the mic is muted, please. Okay. I would like to also thank you for the questions, all the participants and presenters. Thank you very much for the questions you've submitted. We've responded to some already via the chat, and we will follow up on the others that we haven't responded to. It's now 2:30, it is now time, and we've ended. In case you've missed, there is, you can tell us what you thought, and there is a link that you can follow and respond to what you think. Next. So before wrapping up, a quick reminder about how and where to continue learning about ways in which Momentum is working with and for young people. This webinar was the second in a series and was preceded by a webinar last week, also focused on youth. A recording of last week's webinar, Improving Health and Gender Equality Among Very Young Adults, Harnessing the Power of Faith-Based Organizations, can be found on the Momentum website. We'll soon be able to upload the recording and resources related to this particular webinar to that in that same site. Check back soon to find it. Once again, a very big thank you to all involved, to Amy and USAID for introducing the webinar today, to our presenters for sharing their experiences, and to all the participants for your interest and engagement. Thank you, and please tell us what you thought of this webinar by completing a brief survey using the link found here. Thank you once again and have a wonderful day.
Thank you.